Okay. Thank you very much for this kind invitation. Have nothing to disclose. Okay. Well, we gynecologic oncologists are usually seen as well-balanced people, easy people, but this is not always the truth, trust me. We can move in a shades of treatments. When it comes to neoadjuvant chemotherapy, we have that ability to move from one pole to the opposite, from really ultra-conservative surgery to ultra-radical surgery. So, let's start talking about ultra-conservative surgery. For nearly 1 century, all patients were treated the same. You remember that, surely, with a full radical hysterectomy, whether they have a barely measurable microscopic lesion or a 4 centimeters bulky tumors. And this concept changed since Daniel Darchant in 1994 reported his vaginal radical trachelectomy. And it was a watershed because it meant to convince the community of gynecologic oncology that something different could be done, and the opening for fertility sparing procedures. So a woman with a cervical cancer could be treated, and afterwards he also could be a mother. So it wasn't science fiction movie anymore. It became real. So, what's the rationale for neoadjuvant chemotherapy in fertility-sparing procedures? As we can think a little bit conservative, saying that as survival rates are guaranteed in tumors with lesser than 2 centimeters, survival rates are really encouraging. Why take it to chance, right? Well, the truth is that cervical cancer is a highly chemo-responsive tumor, and it reduces tumor mass and hypoxic cells, and also it allows sterilization of occult, perimetrial lymph node involvement. This means less extensive dissection and the decreased need for adjuvant radiotherapy. So, in an early stage, the probability of perimetrial involvement is really low, maybe less than 1%. So, why overtreat? Why increase morbidity? Do we increase morbidity? This is a question that comes to my mind. In the era of ultra-standardized procedures performed at reference centers by gynecologic oncologists, in the era of nerve-sparing technique, do we really increase morbidity by performing a radical trachelectomy? Obstetrical morbidity is what we are talking about, actually. Well, the point is that Professor Maneo Alandoni went one step further. It was in 2004 at the IGCS meeting that took place in Edinburgh by presenting a pioneering work, the Italian experience about chemotherapy followed by conization for preserving fertility in stage 1B1 cervical cancer. So we all thought, oh my God, what's going on here? And later on, we had the complete publication of these authors by separated 1B1 tumors lesser than 3 centimeters with 3 courses of neoadjuvant chemotherapy. This tip also the so-called MONSA scheme, cisplatin, paclitaxel, ifosfamide, or epirubicin, and conization in some cases with a previous lymph node assessment, in many other cases without lymph node staging, but it boils down to high rates of pathological response with encouraging obstetrical results. But let's get back to radical trachelectomy. We still have a limiting factor. This is a tumor that has to be lesser than 2 centimeters because the association with recurrence is much higher when it goes beyond 2 centimeters, especially those between 2 and 4 centimeters. What to do with these patients? Because chemotherapy followed by conization or upfront radical trachelectomy, it means fertility sparing, but if we go with tumors beyond that, okay, we are talking about a patient that is losing the possibility of preserve her fertility. So then it comes this another pioneering work from Marie Planté, inspired by the Maneo experience, about introduce neoadjuvant chemotherapy followed by radical hysterectomy. A preliminary experience with the TIP chemotherapy regime, with laparoscopic node dissection and vaginal radical trachelectomy with nice rates of pathological response. We had also a debate here about gonadotoxicity of ifosfamide, but from then on, many other studies were published, like the one from Robova and many others, showing that it's feasible to add neoadjuvant chemotherapy in order to reduce tumor size and allows a less aggressive procedure that preserves fertility. Here we have the Robova experience that use 3 cycles of chemotherapy, the dense dose chemotherapy every 10 days with the same scheme, and also people who perform neoadjuvant chemotherapy followed by simple trachelectomy. So the range is really wide, and also our experience by abdominal trachelectomy, 5 patients with platinum-based chemotherapy followed by abdominal radical trachelectomy with also good results in terms of radicality and obstetrics. So, to answer this question performed by Professor Sardi and Di Paola more than 30 years ago, we had to know that there is a definite trend towards less radical surgery in patients with low-risk cervical cancer. Also, it has nothing to do with neoadjuvant chemotherapy, but it's important to point out that the SHAPE trial maybe would tell us to treat even lesser these patients with a simple hysterectomy. But unfortunately, this initiative wasn't ignited throughout the world for some reason, and no published study has compared outcomes between patients with cervical tumors larger than 2 centimeters who underwent upfront radical trachelectomy versus neoadjuvant chemotherapy followed by radical trachelectomy, simple trachelectomy, conization. So we had this initiative also from Maria Planté in order to organize or delineate guidelines for the treatment of these patients. As you can see here, tumors with a complete response or a partial response will be candidates to perform after neoadjuvant chemotherapy will be candidates to perform a simple trachelectomy or even a conization. So among many things, this also is telling us that maybe it's time to bid farewell to radical trachelectomy, to welcome simple trachelectomy. So let's move forward. The classic debate. Okay, what to do in locally advanced cervical cancer, neoadjuvant chemotherapy followed by surgery, or concurrent chemoradiation. We love to debate about this at every meeting, at the operating room, at the supermarket queue. We gynecologic oncologists, we always debate about this issue that fortunately has new things to tell us. This ERTC 55994 that was presented by Professor Landoni yesterday or the day before, now show us that it's all relative. Actually, in those 1B bucket tumors, it may be a difference in favor of neoadjuvant chemotherapy, but in 2B, maybe this difference is in favor of concurrent chemotherapy, which seems to be better tolerated and with more adherence to the proposal treatment. But I wonder if these patients enrolled coming from Europe are the same we are treating in countries like Brazil or Argentina. We only, in the public health system, we only have a cobalt energy to perform radiotherapy, and we have malnutrition, homeless people addicted to many substances, whatever. So the adherence to treatment strategies is not the same. We are not treating the same patient here than in Europe. I really like to highlight this topic because it's not minor. And Professor Raspagliese also told us that these high-risk cervical cancer subsets with tumors larger than 2 centimeters, lymphovascular space involvement should undergo concurrent chemoradiation. But we also learned about the influence of the age of the patient at the moment of diagnosis. Young cervical cancer patients may be more responsive than older patients to neoadjuvant chemotherapy. Also, our experience, our clinical alert that I presented yesterday morning. So, last word is not said. Maybe in those patients under 35 years old or tumors larger than 6 centimeters, these patients have to be treated twice, because I always thought we are if we don't identify patients that will need further treatment, this is adjuvant radiotherapy, we are treating them twice. Okay, yes, but maybe these patients need to be treated twice. I don't know. And the problem of free bucket, we have a real issue here, but the answer is quite simple to this relegated debate. Wait for my next talk, so that we can see how complex this is actually. I mean the talk after the next one. Finally, in the other pole, we can talk about neoadjuvant chemotherapy followed by ultra-radical surgery. Yes, we can do that because we move from one pole to the other out of the thin air sometimes. This usually happens. And we had this Italian experience from Benedetti Pannicci and Landoni that tells us that in 4A stage cervical cancer without lateral involvement, or even in recurrent cancer, this patient could show a benefit by the adding of neoadjuvant chemotherapy followed by an ultra-radical surgery in terms of less morbidity, less bleeding in the surgery. I mean, for the local regional control, it could be an interesting option. Of course, as Professor Soderini said, it has to be tailored. Each patient had to be tailored. Extremely thorough, selected patients in every case, so the treatment is never the same. I think this is the last one. Thank you very much.